Week's ABMC Research Minireview. Those of you who don't know me, my name is Jim Janis and I'm a neurologist and head of department within CALHN that encompasses both the Queen Elizabeth and Royal Adelaide Hospital. Before proceeding with this session, I'd like to acknowledge that the land that we meet on today is the traditional lands of the Kaurna people and that we respect their spiritual relationship with the country. We also acknowledge that the Kaurna people as the custodians of the Adelaide region and their cultural and heritage beliefs are still as important to the living Kaurna people today. This week's session provides an opportunity to showcase some of the research that's occurring within the neurology department in CALHN. Professor Tim Keinig, head of the stroke unit at the Royal Adelaide Hospital, I should say. Tim is a highly respected vascular neurologist who's published widely in the field of cerebrovascular disease and is currently the chair of the South Australian Stroke Community of Practice and vice president of the Stroke Society of Australasia. His presentation today will provide an overview of the stroke research being performed in CALHN. So over to you, Tim.
Thanks very much, Jim, and thanks, Sammy, for hosting these, and also a broader thanks to Jim and to CALHN for being very supportive of stroke research at the Royal Adelaide Hospital. So, as you would all know, stroke's fairly common. It occurs in 1 in 4 patients worldwide, probably about 1 in 5 to 1 in 6 in Australia. And depending on how you count it, whether you separate different forms of cancer and infection, it's either the second or third or fourth cause of death worldwide. Intracerebral hemorrhage, even though it's less common than ischemic stroke, causes more deaths than ischemic stroke because it's more severe. And here's a large MCA stroke, which is obviously a very nasty one, a small hemorrhage. But overall, intracerebral hemorrhage has higher rates of morbidity and mortality. And overall, stroke is the leading cause of disability in Australia. This is the model of care that feeds into the Royal Adelaide Hospital. At the moment, we have 3 stroke centres around Metropolitan Adelaide, the Lyell McEwen, us and Flinders Medical Centre. All centres open for acute stroke from 8 till 8, but overnight from 8 till 8, all stroke in the peri-urban area drains to Royal Adelaide. So all stroke that's potentially eligible for acute therapies. We admit around 1,200 stroke patients a year, and to my knowledge, that makes us the busiest stroke centre in the country. We perform around 240 endovascular thrombectomy cases, similarly putting us up on a level with all of the busy centres around the country. Royal Melbourne and Liverpool, I think, are on a similar level. But we cover by far the broadest geographical spread. So not only the peri-urban catchment, where we're the sole thrombectomy centre, but all the way from Mount Gambier up to Broken Hill, out to the western border of South Australia and the whole of the Northern Territory. So we're actually the closest thrombectomy centre to Darwin, and we have retrieved some patients from there. In terms of stroke recruitments, we're a very active site, and we've been the top or second or third recruiter consistently nationwide for many of the recent acute stroke trials. And there's just a sample of the key trials that we've been involved in over the last few years. The Extend IAA trial, which will prove the benefit of endovascular thrombectomy, one of the pivotal 5 trials worldwide. The Extend RCT study, which is looking at thrombolysis and extended window, again, a pivotal study, and the Extend IATNK study, which compared tenecteplase versus alteplase before thrombectomy for ischemic stroke. So these are the studies that have had the biggest impact that we've been involved in, but there's many others, as Jim has said. We have 3 main streams: acute stroke treatments, prevention, and epidemiology. Probably the most active stream is the acute ischemic stroke stream. I've left in bold the studies that we're sort of leading, the others we're participating in. We're performing a TIA biomarker study, which was led by Simon Koblar and the SAMRI stroke team, Anne Hamilton-Bruce and others. And we've performed some interesting studies, and I'll mention one of them a bit later, looking at acute blood flow in cerebrovascular disease. But we contribute to national imaging registries and thrombolysis trials, thrombectomy trials, about to start a stem cell trial for acute ischemic stroke, mesenchymal stem cells, and also a study on reducing stroke edema. Intracerebral hemorrhage, again, we perform some fairly interesting acute intracerebral hemorrhage research, looking at CT perfusion and hemorrhage, involved in hemostatic therapies, stopping the growth of intracerebral hemorrhage, and surgical treatments. The preventative studies are often pharma-based, but we are involved in with Prash Sanders, collaborating with the cardiology team, and John Fitzgerald on the PREDICT stroke study, which is looking at an intensive lifestyle intervention to reduce the risk of embolic stroke. Intracerebral hemorrhage, we participate in the antiplatelet recommencement after intracerebral hemorrhage trial, the ASPIRING trial, which is an international multi-center trial, and we're the national lead for the DOAC cerebral venous sinus thrombosis trial, which is comparing warfarin and the DOACs for CVT. But we're also very active looking at rare stroke variants and stroke epidemiology. Josh Mahadevan, neurologist and PhD student, is running the ASCEND-2 study, a repeat of the ASCEND study led by Jonathan Newbury and Craig Anderson and James Layden back in 2009 in the western suburbs of Adelaide. We're repeating that a decade down the track to see what's happened in terms of the changes of stroke epidemiology over the last decade. We've also been very involved in research into stroke in Aboriginal Australians, and we were also the national coordinator of the VIT cerebral venous sinus thrombosis study, which was published recently in JAMA Neurology. I'll put in brackets there, Stream 4 Recovery. We're about to apply for an MRFF grant with our Flinders Medical Centre and UniSA collaborators using a novel controller of an exoskeleton for stroke rehabilitation. So fingers crossed for that one. Just quickly on terms of preventing ischemic stroke injury, I'll focus on a couple of these aspects. Notionally, there are 4 main ways that you can limit an acute ischemic stroke injury: revascularization, thrombectomy and thrombolysis, reducing brain activity to allow it to hang in there until reperfusion, using neuroprotective peptides or agents, and blood flow augmentation. We participate in a variety of reperfusion studies, and this is a large part of our acute stroke trial work. Lots of them comparing tenecteplase versus alteplase or antiplatelet therapy, or extending it into the acute window later on for ischemic stroke, but also performing endovascular thrombectomy in patients for whom it's of uncertain benefit, and submitting our tenecteplase data to an international stroke registry. In terms of keeping the brain alive until reperfusion, this is very important in South Australia as we retrieve people from very far away, including, as I mentioned, Darwin. So it's around 3,000 kilometres. And to give you an idea of the comparison, that's from Helsinki to Athens. So all of this is our endovascular thrombectomy catchment. So these people are having acute ischemic stroke, and we need to try and keep the brain alive until reperfusion. We are taking part in an international study looking at a compound called Neuroenatide, which will win this guy, Michael Tymiansky, probably the Nobel Prize if this trial is positive. So this is a fantastic bench to bedside story of inhibition of the postsynaptic density 95, the downstream modulator of the glutamate receptor, inhibiting that in acute ischemic stroke. This agent blocks the production of neuronal nitric oxide, which rescues neurons and other structures from death. The trial that tested this initially, the ESCAPE-NA1 trial, we participated in that was published in The Lancet, was neutral, but interestingly, it was positive in the no alteplase group. So there was a substantial benefit in the no alteplase group, and subsequent work showed that alteplase actually deactivates Neuroenatide. So therefore, the next phase of this study is the ESCAPE-NEXT study, looking at Neuroenatide versus placebo in patients who are not eligible for TPA, but who have a large vessel occlusion and a severe ischemic stroke under 12 hours. In terms of keeping the brain alive, other than neuroprotection, we can try and increase blood flow within the brain until reperfusion occurs. And we have performed this study looking at inducing cerebral relative hypertension, and we're about to lead this next study, inducing hypertension and acute ischemic stroke. In stroke, the brain in normal blood flow, brain autoregulation keeps cerebral blood flow exactly the same, regardless of your cerebral perfusion pressure. But when you have a blocked artery, the brain is in this section of the curve here, and your blood flow is directly proportional to your driving pressure. We looked at inducing relative cerebral hypertension with the Head Start study, looking at whether Trendelenburg positioning increases cerebral blood flow. And we did that by custom designing this wedge and looking at people in the CT scanner. This isn't a real patient. He looks far too happy, but this chap is a real patient. You can see how red my face goes. The blood does seem to rush to the brain, but we were able to prove this using CT perfusion imaging. This is just the first 13 patients. The complete trial is under review for the International Stroke Conference in February. Hopefully we get a gig there. But we have shown that there's a substantial reduction in the area of the ischemic lesion with heads down positioning. The next phase of this research is to look at blood pressure augmentation. We've had a pilot patient already, a patient with multiple intracranial occlusions, the relative hypotension. It was awaiting bypass surgery, very severe and broad reductions in cerebral blood flow. This Tmax greater than 10 lesion was 72 mils, which is the area in here in red, very severely hypoperfused tissue. By augmenting blood flow to 160, we were able to substantially reduce that lesion and essentially eliminate the area of severe cerebral blood flow reduction. So we aim to test this in the acute stroke setting over the next couple of years. The other trial I want to mention is the Evacuate randomized controlled trial, which I'm running in conjunction with Amal Abu-Hamdan, the surgical PI here at the Royal Adelaide, and Bruce Campbell and John Laidlaw, the medical and surgical PIs at the Royal Melbourne Hospital. And this is supported by the MRFF. This is looking at ultra early, minimally invasive hematoma removal using this surgiscope and this evacuator supplied by Aurora Life Sciences. I realize time's kicking on, so I'll get on with that. But this is a trial that we're pushing out across Australia and New Zealand and maybe internationally. We've just really started recruitment. It's a little bit slower than expected because of COVID in particular in Victoria and New South Wales, but we're hoping to be able to prove the benefit of ultra early acute surgery in intracerebral hemorrhage. So that takes me to the end of my 8 minutes. In summary, we're a very active stroke trials unit. We're running 11 active randomized controlled trials, 3 are pending, and we participate in multiple registries, and this is across the whole spectrum of stroke. It's been a very exciting decade to participate in stroke research, and I'm sure the next decade will prove just as interesting. And I'd like to acknowledge in particular our stroke trial staff, the Roy Drew, Raj Khanna, and our head stroke trials nurse, Jenny Cranefield. Also our main collaborators through the Royal Melbourne Hospital, the Australasian Stroke Trials Network, who coordinates stroke trials across Australia and New Zealand. And of course, my stroke colleagues, including Jim and the other stroke consultants who help randomise and recruit patients, and the stroke registrars, stroke fellows and stroke nurses, and the Hospital Research Foundation Stroke, just rebranded from Cure for Stroke Australia, who have been very generous in their support of the stroke research at the Royal Adelaide. Thanks very much for your attention.
Thanks very much, Tim. Do we have any questions? Not seeing any questions on the Q&A panel. We've got a few people online. Just a question to get things started, Tim. If I'm a young up and budding PhD potential, what's the area of need in research? What are the burning questions in stroke medicine that need to be addressed?
Very good question. The stroke reperfusion still has a little way to go, that we still haven't really pushed the boundaries of thrombolysis and thrombectomy. It's hard to run these as an individual researcher, of course, but that's certainly an area of need. Intracerebral hemorrhage research is a huge area of need. These patients, we don't have great treatments for intracerebral hemorrhage, and stroke recovery, I'm sure, will be an enormous area over the next couple of decades, in particular. Sort of mind-body interface, robotic interfaces, and augmented cognition, and other sort of AI-assisted recovery technologies.
Thank you, Tim, for a great talk and a great overview. I'll conclude the session. Thank you very much.